Well, thank you so much for staying with the Monday Report. You're just in time for the town hall session where we're discussing the cost of health care. We'd like to hear from you at Trevor Mbija at Citizen TV Kenya. Use the hashtag Monday Report. Also send in your video questions. We'll try and squeeze them in over the next 45 minutes. Dr. Peter Kamunyo is already here, CEO NHIF, and Honorable Sabina Shege, Chair Health Committee, is also joining us. Thank you so much for making time. All right, so let's go straight into it. And Honorable Sabina, I'll start with you because I had you engaging the CS earlier on this same issue that we are focusing on. Why are medical services so expensive in this country? And who even decides the rate card? How come sometimes you go to one hospital, it's 3,000 consultation, another one it's 6,000, another one it's 9,000? Why can't we just standardize it?
Well, I think it's been a journey, and we commercialized our health sector. And I think that's when we started losing it. Earlier, when I joined the health committee, we had a discussion with the board, the medical board. The first thing we discussed was about the costs, and especially the doctor's fee. And we were in agreement with the board that they were to review. I think by that time, they reviewed with 20% down, because some of the costs that were there for a C-section, when they say a minimum of Kenyan to pay 80,000 Kenya shillings to a maximum of 180, we had a discussion on how many Kenyans would afford that. And so from there, then we also were to have a conversation with the Pharmacy and Poisons Board because of regulation also for our medicines, because you'll find a specific painkiller costing 5 shillings in this street. When you go to the next street, it's 15 shillings. Yeah. When you go to a hospital, you'll be charged the same one at 500 or even 1,000. So it's a free market, and there have been no regulation or proper regulation. And we have been consulting and finding out what we can be able to do. We are hoping through NHIF now that we are doing some amendment of NHIF Act, that we'll be able to harmonize, where if a patient goes to Kenyatta National Hospital, gets even a super machine and does an X-ray, if it costs 5,000 or even 1,000 Kenya shillings, will not expect that when they go to a private hospital, they'll be charged for such an extent, sometimes even with a lower level of such a machine, that they are charged 15,000 because you have gone to a private facility. Yeah. And I think when NHIF has been benefiting, and we have had in this conversation with the board and even the CEO before, benefiting a lot of private hospitals. Looking at the uptake from the public hospitals and the private hospitals, we've been spending a lot of money in the private sector. And so we have agreed that we are going to have to regulate through NHIF, such that we'll have specific amounts that should be charged to a specific service. And then with that, then if a specific hospital then want to be part of the NHIF or to be enlisted to be part of NHIF, then they cannot charge a patient more than that. Yeah. But it has been unfortunate, and especially when the COVID came, and where, the prices have just been ridiculous because anybody can charge a PPE whatever amount. Yeah. And you find that a patient maybe was admitted, they have had oxygen, nothing much was being done. But if you look at the bill, Kenyans have been exploited. And today, that's when I had a conversation. We initially had a meeting with the health committee and with the medical board. Yeah. And we agreed that we're going to have a further meeting next week so that we can now further examine and see what are we going to do to help Kenyans. Yeah. And so there is hope. At least for once, the minister agreed that the ministry must come with a policy. Yeah. With the help of now what will come up from NHIF, with the help of the medical board, we can be able now to come up with a policy on how the pricing and the cost of care in our health sector can be harmonized, because at the way we are heading, and especially during this COVID, we have people having a free way. They can charge any amount. The relatives are desperate. They're not able to actually come back and complain how many gloves did they use, how many, somebody's in ICU. You're being charged maybe 180,000 per day. Then you find that even the glove that has been used in that ICU, any other item that was used in that ICU is separately charged. So you ask yourself, was the room costing 180,000? Or what was the cost of 180,000 for somebody to be in an ICU? Is it because of the care, or what is it? So this is the kind of conversation we are having. But at least there's light at the end of the tunnel as we work on the amendments on NHIF, and we make sure that we also bring in the issue of UHC. Because what we are saying, if you cannot afford, the government must come up with a formula of how we're able to tell the person who cannot be able to afford. And then how do we caution that person such that when they go to hospital, they'll get free care, they'll be able to go home and they don't have to sell their land or even to do a fundraiser to raise the amount.
Okay.
And I think we started with taking care of 1 million households. I've already given the CU, we have given them 6 billion. I'm hoping they have started working on it. So that at least, even if it's COVID, we have people now who can be taken care of, whom the government will be taking care of. Those are the indigents, the ones who can't afford.
Okay.
And what NHIF is also proposing, then the people who can afford, then it should be mandatory for them to support NHIF, and even for the voluntary contribution, so that then we can be able to have, you know, somewhere that we can, the people who can afford, who can't afford, can be backed up through UHC. And I think UHC, we have talked about it, and some people have said we lost UHC and started talking about other things. But I can tell you we are on course. And hopefully by the end of this week, once we pass the amendments, the NHIF amendments in Parliament, I'm hoping we can be able, they can be able to be assented by next week, and then we will roll out.
We'll implement. All right. And Dr. Kamunyo, is that the solution? Because the Deputy President, William Ruto himself, twisted something here and said the NHIF amendment bill is 4 years behind schedule, delaying the rollout of UHC. Tomorrow is the single most important day in the life of the 12th Parliament as Kenyans await the passage of the bill so that millions of struggling families can have access to health insurance. Is this the silver bullet?
Indeed, it is the silver bullet, Trevor. And it will be very good. In fact, Mheshimiwa Sabina here has painted the picture very, very, very well, because the challenges that we're having in terms of rising costs of healthcare, which is what you're discussing today, it is good for us to understand healthcare costs. And somebody must pay for it. So whether it is we're paying out of pocket, whether we're paying through government is supporting, or whether we're paying through insurance. There's also the saying that we are all one illness away from poverty. I'm sure you know the statistic here in Kenya that about 1 million households actually become impoverished every year due to catastrophic healthcare spending. Now, how do you cure all this? Since we cannot bear the cost ourselves, the silver bullet is actually that risk transfer. That we remove that risk of out-of-pocket expenditure. As you've seen with the story that you had run the other day about people being detained in hospital, etc., because of healthcare costs. If that risk at the point when they were going to hospital had been transferred to NHIF, for example, or any other third-party payer, if they can afford, they would not be in that predicament. So how do we get ourselves into that position? NHIF has been on this journey for universal health coverage for a very long time, 55 years now and counting. And what we've been pushing for is that for every Kenyan to be covered under NHIF. And we've worked progressively to ensure that the packages that we have are able to address the needs of the Kenyans.
It's silver bullet, you say, but that same bill proposes to insert a new section, 15A, to make it mandatory for any person who has attained the age of 18 to be a beneficiary and a registered member of NHIF. You're essentially forcing everyone to be part of NHIF.
Correct, and that, in my opinion, that should have been done a long time ago. And why do I say that? Because we have the two groups, you and I, who are employed, where it's statutory. So our salary is deducted to pay for NHIF. And every time we have a need, we actually do get services. Now, for the voluntary group, what has happened and what the trend has been is that many individuals pay only at time of need. And this is because a lot of us do not understand the concept of insurance, whereby you pay something small, and then should you have an adverse occurrence, your insurance comes and pays for you. So what has happened is that progressively we've been having people who come in, pay for a service, pay for their premium, only when they need to have a treatment done. They need to go have their hip replaced, or now, like we're seeing the trend, is individuals who have chronic illnesses are the ones who tend to stay on and remain consistently contributing. It is shocking to learn that in the last financial year, for example, only 24% of the voluntary members were active at the end of the year, meaning that the rest of the 76% had paid at some time in the past, enjoyed the service, and then defaulted on payment. Now, what this does for this group is that it creates a big strain on the fund, because the contributions that are being paid, being very small, but for large benefits, will not be sustainable in the long run. And the concept of insurance is pooling the risk, so that Right now, when I'm well, I'm paying my 6,000 annually or 500 shillings per month. If I do, God forbid, require to go for surgery, the scheme pays for me 180,000.
Yeah.
And if you divide that, that would take so long even to recover. But there are those who will not require that service at that particular point in time.
Okay.
And then the other thing that I would like to mention on that, as you're saying, it is not forcing. It's actually encouraging you to be protected. Because the monies that are spent on healthcare, whether you spend them on insurance or out of pocket, we still spend them. But we are spending them in a disorganized fashion. If you look at the WhatsApp groups that you're in right now, contributing for people in hospital, it's a lot of money. The other day I was asking a friend of mine, saying on average, every month he's spending about 6,000 shillings in contributions. If you look at a whole year, how many families would that have supported using our premiums? Yeah.
Let me bring up another tweet from Professor Alfred Omenya and bring in Honorable Sabina Shege on this. And Omenya mentioned that hospital bills in Kenya is about 14 million for 35 days. That's the tweet on air now, in ICU. This is approximately 400,000 shillings daily. Is this a country or are we in hell? And Mheshimiwa, you're the one who said that we've commercialized healthcare. But we are looking up to you. You seem to be lamenting just like the rest of us. Have you essentially then failed Kenyans in terms of passing policy?
No, policies are passed by the ministry, and as we do the legislation. What I would say, and I said when we started actually my committee, the first thing we addressed was the issue of what had been given. You know, we had a case with one of the hospitals, I think it was Mpisha, where a patient went in and they had an accident and unfortunately they passed on, and then the family had a bill and the body was retained, and it was a big story. And when they came in, we went through the bill on what had been charged. And unfortunately, the hospital based their charges on a guideline that was given by the board, by the medical board. And so that's when we called them in and said, okay, let's look at it, you know. And we went through with the doctors, even in my committee, and we agreed on a reduction. By then we started with 20%. And we also agreed now that the Pharmacy and Poison Board is also supposed to regulate and look at the cost of the medicines in Kenya. But unfortunately, as I said, you know, when somebody opens a private hospital or a private facility, by the time you go into a private facility, you sign in to whatever conditions they give you. And so unfortunately, that's why we say the ministry, and we were in agreement today with the minister, that they must come up with a policy to actually guide, you know, what's the limit. And that's why I said with NHIF and now with the new reforms that we have started, it has been 3 years actually, not 4. And you know, we started with the pilot program where we went to Nyeri, was Machakos, Isiolo, and we tried to give everybody an NHIF card within the counties. And then they saw what was working and what couldn't work. Then secondly, then we looked at the NHIF and decided let's reform NHIF. And now we are doing it successfully. Once we pass this amendment, then NHIF would be our guide. And so all is not lost. They will guide us. If I go for an X-ray, if I go for a C-section, because for now, we have Linda Mama, a program that is fully funded by NHIF, by the government through NHIF. So if a mother decides to go to this facility, they should be charged the same. Because unfortunately, you find that you find it being charged cheaper. I gave an example, maybe 500 shillings in a public hospital, then 15,000 shillings in a private hospital. You find the same doctor who was attending this patient at a public facility is the same one who is in the private sector. So we must have a conversation within the sector. And I think it has been going well. We have had a lot of consultation. And so that's why I said all is not lost. And at the end of the day, you know, when I talked about the ICU charges and everything else, the most unfortunate is when somebody passes on, or when somebody is well, then they are detained in a hospital. You know, one thing that Kenyans should know, or even they know the medical facility, that the law does not allow anyone to detain a dead body. Unfortunately, we even have people who are passing on because of COVID, and you know, we are supposed to dispose immediately. And then we have facilities even, you know, moving a body from their facility to go to some morgues that they have an agreement with, so that then they can now force the family to pay. I know we are Africans. And at the end of the day, no one would want even 2 or 3 days they are keen to spend in a morgue then for them not to bury them because they want to hide what they can afford. So some of these things are even, you know, from the human perspective. But anybody who has gone to court to challenge any facility that has detained a body, they have all won the cases. So it's only that sometimes we don't know about our right, and even in the Constitution it's very clear. And so even the code of conduct, it's there. It's very clear on how these health facilities or even doctors should behave. And so this kind of a conversation, I think, is because people have been fearing sometimes, and especially when you have lost a loved one, you don't even know where to reach out. Fortunately, a lot of people are able maybe to reach to our offices, and we're able to guide. And I'll also say anybody who is facing such a challenge, it is important that they go to the medical board. And I think Yumbia, the CEO, has really explained to Kenyans the processes that they should follow. But before we even end there, before even to get to the family to go beg a facility to release a dead body, before we even go to beg a facility to release somebody who was well, if somebody is well, why do you want the person to continue eating your food, occupying a bed that can be occupied by somebody else? Because you want them, it is important for them to have a way where they can be able to say, I can afford 200 or 1,000 shillings per month. And then they let the person go. If they go and get some money, they can come back. But before even we go there, what we are saying with UHC is that those families, the government will come up with a way of establishing that these are indigent, these ones cannot afford. So there are questions that when you go to a facility, by the time, and I think one of the hospitals that have been very successful in this, it is Moi Teaching and Referral, where we have not had cases of body being detained or people being detained in the hospital, because they have a very proper social, department, where by the time you get in their question, you are asked, by the time you are admitted, they're able even to follow up, they know who visits you, they can be able to tell whether this person, whether you keep them here even for a year, they will not be able to afford. And so they release them. But also, if you're able to implement the Health Act 2017, one of the things that were recommended there was about emergency medical treatment fund that the ministry should have, so that also some of these facilities, when they are able to release these people to go, then we'll also not run them, out of business, that we can be able to reasonably negotiate with them. But hopefully, once we are able to implement UHC, once we're able to collapse, because we have so many programs that currently Gamori and his team, they are conducting. We have Linda Mama. Linda Mama targets those women who are not able also to afford. We have a cover for our secondary school students. We also have a cover for indigents. We have a cover for elderly. If you're able to collapse these small groups, the amount of money, we give 6 billion for the indigents now. The amount of money can even be able to cover for now 4 million Kenya households. And we talk about households, that means almost 20 million Kenyans. Then the story of people being detained in hospitals or the people, bodies being detained in the morgue, it will be a story of the past. And that's why, and I think a lot of people now are coming in to support Parliament in what we are doing to support NHIF with the amendment. And hopefully I would like to urge many members of Parliament, because we see them in the political meetings complaining that the Agenda 4 has not been, achieved. Where they don't know a lot of background has been happening. And hopefully by the time we finish this week, we will be able to bring some new hope and a new light within the health sector.
All right. Dr. Kamunyo, if that amendment bill is passed, will NHIF be able to cover everything?
Yes. Remember, first of all, that the bill is addressing very many issues to ensure that we are able to, one, provide an expanded cover to most Kenyans, and secondly, to be able to also have a sustainable fund. This issue of costs, number one of the biggest challenges is the model that we use for paying hospitals or reimbursement. Traditionally, this fee-for-service model, whereby whatever is claimed is what we pay, already is fatally flawed to push for even the hospitals to continue charging more. The patients who are detained in hospital, the hospital is not complaining as they detain them. Why? Because they're still getting paid the daily charges, etc. So looking at the model of reimbursement is very important, whereby we reverse the incentive and go towards packages. Now, you ask the question, will this bill help us to get to universal health coverage? Yes, indeed. And how so? Number one is that everybody who can pay should pay. And then those who cannot pay to be identified and supported. And from the last Kenya National Bureau of Statistics census, it identified 5.1 million households that are indigent, meaning that they cannot afford basic necessities of life, including healthcare. So if we are able to support those 5.1 million, we will be able to get to a state of UHC, because the rest, according to the bill, ought to pay because they can afford to pay, as it has been seen.
Yeah.
Now, the other issues in the bill that are also to support that is ensuring that the fund is protected from issues like first loss, like what we're doing right now.
Yeah.
In the previous, when we introduced packages, and I'll name a few, like the radiology package, for example, where we pay for our MRIs, the CT scans. The reimbursement that we picked based on research that we did is actually enough to cover even in private hospitals. So what did that happen? What ended up is that also private insurers were riding on that, and NHIF now is literally paying for a lot of these benefits. Yeah. Looking at also things like oncology package, which we cover extensively, almost the entire cost of the treatment. So having us taking the second, what we call the second loss, and meaning we don't abdicate our duties, we still pay for bed rebate, we still pay for outpatient, but we only come in after the private insurance has been exhausted.
Okay.
So this are going to help us get to that state where every Kenyan has access to the healthcare they need without financial hardship.
All right, I have to take a quick break. When you come back, Mheshimiwa, I'd like to find out from you. There are people who are watching right now and they're sending messages saying, I have a patient detained in different hospitals, I have a body detained in different hospitals. Where do they start? One particular disease that has led to a very sharp rise right now in the number of cases that we're seeing here is the COVID-19, but we'll be back with that in just a bit. Also, keep your views coming at Trevor Mbija at Citizen TV Kenya. Use the hashtag Monday Report. See you in a bit.